Today we will be discussing the solitary pulmonary nodule, and these are some issues that we will discuss. We will discuss pseudonodules, the approach to the solitary pulmonary nodule, differential diagnosis, calcification enhancement, PET scanning, a little bit about Fleischner Society guidelines and Lung-RADS, and we will also talk about some specific lesions. So starting with a common problem that we can see on chest radiographs, sometimes we will see a nodular opacity like this overlying the lower portion of the chest. And the first question that comes up is this nodule really in the lung, or is this a nipple shadow? And usually the way we resolve this is with a repeat radiograph using nipple markers, and if the nipple marker corresponds exactly with the location of the nodule, then we assume that this represents a nipple shadow. What you can also do is a slight oblique view, and when you do that, you can show that the nodule actually moves with the nipple marker, again confirming that this represents a nipple shadow. So if I show you this case, we can see this small nodule here where the arrow is, but a subsequent chest radiograph, it looks like this nodule has moved. So how can we explain that? When we look at both radiographs here, we see that the nodule is here lower in the chest on the first radiograph and appears to have moved to a higher position on the subsequent radiograph. Notice, however, the position of the scapula. In the subsequent radiograph, the patient's arms are raised, as this was a PA chest radiograph, so this also represents a nipple shadow. So with raising of the arms, this will also raise the nipple shadow and change its position relative to the background structures there within the thorax. Now hopefully, if you have a case like this where you have two completely symmetric nodular opacities, we have no problem in saying that these represent nipple shadows. Here's another example of a small nodule. Notice, however, that in the periphery there is this ring of lucency. So what is the significance of that ring of lucency? Well, many times this indicates that the lesion is on the skin. I will caution you that this rule is not 100% reliable, but it does suggest that the lesion we're looking at here may be on the skin, and in this case this was confirmed on the CT scan. This represents a skin tag here, simulating a nodule on the chest radiograph. Here's another common problem. We see this nodular opacity here overlying the anterior margin of the first rib. This is called a student's tumor. This represents some costochondral calcification here, and it tends to occur right there at the costochondral junction of the anterior first rib. Some clues are that the borders disappear exactly where it is touching the rib, and often this is dense, just like calcium, and this can be confirmed on CT, and sometimes even on CT, because of partial volume averaging, this might look like it's a calcified lesion actually within the lung parenchyma, where this really represents just costochondral calcification there of the anterior first rib. So that's called a student's tumor. So here's another example where we have this lung nodule here, pretty easy to see. Now if I show you the CT scan and I ask you where is the nodule, so take a good look at the CT and tell me if you can see where the nodule is. I will tell you that the nodule is on this image. So where is it? Well, it turns out that this is a bone island. So here it is right here in the anterior rib. And this can also, these bone islands can also simulate lung nodules. If we see on serial chest radiographs that the nodule is always in the same location relative to the rib, then it's a hint that the lesion itself is related to the rib. So another common problem that we might run into is a nodular opacity like this, also overlying the rib. This represents callus from a rib fracture. So you can see that also on the CT scan. So again, it's important, especially if you have serial chest radiographs, if you notice that the nodule always remains in the same relationship to a particular rib, that we may be dealing with a bone lesion and not really a lung nodule. Another problem that we can run into here on the lateral chest radiograph, it looks like we have these ill-defined nodular opacities overlying the vertebral body. Well, these represent osteophytes, and often they're found in this typical location on the lateral chest radiograph. They seem to be centered right along the intervertebral disc spaces. Now, these are easier to see when we take bone radiographs. So these are radiographs of the thoracic spine. So here the bone detail is much better demonstrated, and it's easier to demonstrate that what we are seeing here are actually osteophytes overlying the intervertebral disc spaces. And also on the frontal view, you can see these osteophytes much easier. Another example, on the lateral view, we kind of have this ill-defined nodular opacity overlying the vertebral bodies. Notice again that it seems to be centered at the disc base. Here there is some osteophyte formation on the lateral view, and the CT scan again confirms that what we're looking at here is osteophyte formation, simulating a lung nodule on the lateral view. This we can also see here where we have an osteophyte adjacent to the lung. We can see this area of ground glass attenuation with somewhat irregular margins. So this represents some scarring that can occur within the lung parenchyma, right where an osteophyte there is poking into the lung parenchyma. So that can result in a fibrous reaction there and some scarring in the lung. And we don't want to mistake that for any type of malignant lung lesion. Here are the bone windows. You can see the osteophyte formation here right next to the lesion in the lungs. And then here on these coronal reconstructions, you can actually see the osteophyte poking out into the lung. And so what we have here is a little bit of a fibrous reaction where that osteophyte is projecting into the lung parenchyma. So this has also been described in the literature. So here's an osteophyte projecting into the lung parenchyma. Here's some ground glass opacity representing scarring there within the lung as a result of the osteophyte. Now, what about this case? So here again, we have what looks like a nodule here on the chest CT scan. Here it is on the lung windows. So if I give you a few seconds here to think about this case and what do you think this might be? Is this a real lung nodule or is that something else? Well, it turns out that this represents a pericardial recess here, which is commonly found in relationship here just underneath the right inferior pulmonary vein. So here it is on the coronal view. You can see it very easily. And then here on the axial view, there's part of it. And if we happen to take a cut right through the recess, then that can simulate a lung nodule on the axial image. So when we do additional reconstructions, then we can see that the lesion here is related to the right inferior pulmonary vein. It's also a fluid attenuation. So this is a common thing that is seen on CT scans. This is a pericardial recess for the inferior pulmonary vein. You don't want to mistake that for a lung nodule on an axial CT image. So those are some examples of pseudonodules that we don't want to mistake for real nodules. Now, what about a case where we have an actual lung nodule? So first, what is the differential diagnosis for a lung nodule? And secondly, what do we do about it? How do we go about working it up? Well, this patient had a CT scan, and we can see that this is a non-calcified nodule here. So what else can we do to work up this nodule? The findings here are still non-specific. The first thing is when you're dealing with a lung nodule on a chest radiograph, the first thing we want to do is to get old films, and we'll talk about why that's important. If we don't have any prior studies, then in the workup we will do CT, trying to decide if the nodule is benign or indeterminate. If a nodule has some particular features on CT, we can say the nodule is benign. It does not require further workup. On the other hand, if the nodule does not have those features that we would use to classify it as benign, then we would say the nodule is indeterminate and will require further workup or follow-up. In terms of the differential, there are three things that make up the differential diagnosis for a solitary pulmonary nodule. They are granuloma, lung cancer, and hamartoma. So those are the three most common things in the differential diagnosis for lung cancer. In this particular case, what else can we do to work up this indeterminate nodule? Well, if the nodule is greater than 8 millimeters, you can do a PET CT, and in this particular case, we see that there is no increased metabolic activity within this nodule. So this nodule then has a very high probability of being a benign lesion. So the approach to the pulmonary nodule, the first thing we want to do is we want to get old films if we see a nodule on a chest radiograph. If the nodule is unchanged in greater than 2 years on a chest radiograph, then there's a high probability that the nodule is benign and probably does not require workup. In terms of describing the lesion, the definition for a nodule is it must be 3 centimeters or less to classify it as a nodule. If it's greater than 3 centimeters, then we call it a mass. And those lesions, once they've increased in size beyond that 3 centimeter threshold, they have a much higher probability of being malignant. Border characteristics, of course, if you have spiculated or ill-defined borders, then you will be more concerned about malignancy. We will talk about presence of calcifications, and in ancillary findings that might also change your differential diagnosis. Lymphadenopathy, pleural effusions, other nodules, these ancillary findings might change your differential diagnosis. Now, in terms of the differential diagnosis, granuloma, neoplasm, hamartoma, these are the three most common entities in the differential diagnosis for solitary pulmonary nodules. These will make up 95% of cases of solitary pulmonary nodules. The next step, if we don't have old films, is to do CT. Again, the idea here is to try to classify the nodule as benign or indeterminate, depending on what the findings are on the CT. In your textbooks, you will see many things listed in the differential diagnosis for solitary pulmonary nodules. Remember, however, these three, neoplasm, granuloma, hamartoma, these will make up over 95% of entities that give us solitary pulmonary nodules. So if we start with this case, we see this chest radiograph. Here's a nodule here. Notice, however, that the nodule is quite dense. It looks as dense or maybe even denser than the bone. So we suspect that this nodule is calcified, and that is confirmed on the CT. So this nodule is completely calcified. So this is a case where we're dealing with a granuloma, completely calcified nodule. So this nodule would not require any further workup. Another example here where we have a nice well-defined nodule on the chest radiograph. If we look at this carefully, we notice that in the center it appears to be denser than the remainder of the nodule. There is a central calcification. That's another feature of a benign nodule. In this case, this is also a granuloma here with central calcification within the nodule. There's another clue. Here also we have a calcified right paratracheal lymph node. This patient had history of exposure to tuberculosis and developed calcified lymph node here and a calcified granuloma there within the lung parenchyma. Another benign nodule that does not require any further workup. This particular nodule also has central calcification. However, notice here that the calcification is somewhat amorphous, and the term that we use for this is popcorn calcification. So popcorn calcification is associated with hamartomas. So this is also a benign lesion. A hamartoma does not require any further workup. When we look at this next case, here again we have a nodule with some central calcification, but notice also that we have this peripheral ring-like calcification in this nodule. This particular appearance is specific for a particular entity. I'll give you a second to think about it. What do you think this is? This is a histoplasmoma. So this ring-like peripheral calcification is specific for histoplasmoma. Now, what about a case like this where we have this very tiny nodule that's well seen on the chest radiograph? How do we know that this nodule is benign? Well, the answer is because we can see it. So a nodule that is this small, if we can see it on the chest x-ray, usually means that this nodule is calcified. So if this were of soft tissue density and it were this small, just just a 1 millimeter in size there, we would usually not be able to make it out on a chest radiograph. So such a sharply circumscribed, well-seen nodule that is that small is usually calcified, and this is also confirmed on the CT scan. On the other hand, if we see a nodule like this, is there any way that this nodule can be malignant? So we see a calcified nodule here in the lung, in the lower lobe. So we would assume that, well, here we have a calcified nodule. This must be a granuloma. But is there any circumstance where that might not be the case? So I'll give you a second to think about that. And the answer is, if the patient has an osteosarcoma or other type of tumor that can give you calcifying metastases like osteosarcoma or chondrosarcoma. So in these cases, it's usually not a surprise. It's usually well known that the patient has a malignant tumor like an osteosarcoma. And the point is that if we see calcified nodules in the lungs in patients like this, we cannot assume that these are calcified granulomas, that these may represent calcifying metastases. In this particular case, the patient also has an additional lesion here in the left lung that would increase your suspicion for metastatic disease. So this was a metastatic lesion from an osteosarcoma, which can give you calcifying metastases. So here we have another nodule. What do we think this nodule is? I'll give you a second to think about that. And the answer in this case, notice that there is this low attenuation in here. This is fatty attenuation. How do you tell it's fatty attenuation? Look where there's fat elsewhere on the image. Here you have the fat here in the subcutaneous tissues there, and it's the same attenuation as this area here in the nodule. Therefore, this is fat within the nodule, and we can say this represents a hamartoma. A benign lesion does not require further workup. Risk factors for malignancy, this is no surprise. Older age, history of smoking, history of extrathoracic cancer within the last 5 years, family history of malignancies, especially within the chest, emphysema, of course. These all increase the risk of malignancy. Now, nodule size, nodules that are less than 4 millimeters in size, even in smokers, have a very low probability of being cancer. On the other hand, if we have nodules that are larger than 8 millimeters in smokers, then the probability for cancer goes up substantially. The larger the lesion, the more you're going to be suspicious about malignancy. Border characteristics, again, no surprise, spiculated borders, lobular lesions, pleural tags, these all increased your suspicion for malignancy. Growth, and for this you need to compare with prior studies. Of course, if the nodule has gotten larger, you are going to be suspicious for malignancy. Attenuation. Remember, central calcification is associated with benign lesions. However, if the calcification is eccentric, that can be associated with malignancy. Solid versus subsolid, cavitation, air bronchograms, these things are also important, and we will discuss why when we get to that in a few minutes. For whatever reason, lesions in the upper lobes have a higher probability of being malignant compared to lesions elsewhere within the lung. In terms of CT findings that confirm that the nodule is benign, there are certain benign patterns of calcification. Central calcification usually indicates a benign lesion. However, if the lesion is greater than 3 centimeters or if the margin is spiculated, then we cannot use this rule of central calcification. Calcification of the entire lesion, again, usually means the lesion is benign. Laminar concentric calcification, we've seen an example of histoplasmoma, and popcorn calcification is associated with hamartoma. Fat within the lesion, also associated with hamartoma. CT densitometry, if the lesion is dense, greater than 200 Hounsfield units, it usually means there's calcification in the lesion, and also stability over time. If we have a solid lesion that is unchanged in 2 years, then we can usually assume that that is a benign lesion. On the other hand, lesions that have any ground glass attenuation, they need to be followed for much longer periods of time. So we usually follow those for 5 years before we can say that the lesion is benign and does not require further follow-up CT. Size, we've talked about small size, especially less than 6 millimeters, usually indicates a benign lesion. Periphyseal location, we will talk about these periphyseal nodules also in a few minutes. And lack of enhancement, less than about 15 to 20 Hounsfield units, provided you've done a properly protocoled CT enhancement study, is also associated with benign lesions. So in terms of calcification, central calcification is benign, popcorn calcification is benign, laminated calcification also benign, so this can be associated with histoplasmoma, granuloma here, and popcorn associated with hamartomas. Stippled calcification, however, this is not a definitely benign type of calcification that can be associated with malignancy. Now, how can we detect calcification in pulmonary nodules? Low kVp chest x-ray. The lower the kVp, the better it is for detecting calcium. So near the K edge of calcium, about 68 kVp technique is good technique for detecting calcium. Plain film tomography, which is not done anymore. Dual energy chest radiography, some places do this, and this can be helpful for detecting calcification. And of course, CT is also the best way, for as far as we're concerned, for finding calcification. Here's an example of dual energy subtraction where we take different exposures at different energies, and with manipulation of the images at the high kV here, this is shows you less detail for calcification. The low kVp image, though, this is more of a bone image. This gives you better detail for calcification. And then what we can do is we can subtract the bone image from the entire image and give you more of a soft tissue image here, where the bones and detail has been subtracted out. And you can see that this particular nodule shows up better on the bone image, and we really don't see it well here on the soft tissue image. So dual energy subtraction here tells us that that is a calcified nodule. With CT scans, sometimes we might run into a case like this if we've used intravenous contrast. So we'll neglect the other abnormal findings here, but we have this small nodule in the anterior mediastinum. The question is that an enhancing lesion, or is that a calcified lymph node? Well, fortunately, this particular case was done with a dual energy or spectral CT, and here we can manipulate the image data to determine whether this area of increased attenuation is calcium or iodine. So this is the general image that we're looking at here. In this image, what we're doing is we are removing the iodine, so this is almost a virtual non-contrast image. Again, this was all done with post-processing of a spectral CT scan. You can see that the iodine has been removed from the blood vessels, the contrast has been removed, and this lesion remains increased in attenuation. So this represents then calcification. This is a benign calcified lymph node here in the anterior mediastinum. Here on this image, what we're doing now is we are keeping the iodine, so you can see that the attenuation of the blood vessels here is increased compared to the attenuation of the bone, and we are removing the calcium. So therefore, where there is bone and calcification is dark, and you can see that the lesion here does get dark. Again, also confirming that this represents a small calcified lesion. So this is how spectral CT can help you also differentiate between calcification and enhancement. Now, what about a lesion like this? Here we have a lesion with central calcification, but notice it has spiculated borders. So because of the spiculated borders, we cannot assume this lesion is benign. So this could represent an adenocarcinoma with calcification, or maybe it's an adenocarcinoma that is engulfing an adjacent granuloma. So spiculated margins, we can't use the rule of central calcification indicating a benign lesion. With spiculated margins, we do have to be concerned that the lesion might be malignant. Now in this case, we have an image without contrast, and here we have an image with contrast, and you notice that there really is no appreciable enhancement in this lesion. So is this lesion benign, and how confident are you that this lesion is benign? Well, it turns out if the study was done properly, you can have a very high confidence that this lesion is benign. So here I've outlined findings in the paper that describe this. The important number here is the negative predictive value. So if the lesion here enhances less than about 15 to 20 Hounsfield units, the negative predictive value is 99%. And in a follow-up study where they were able to reduce the threshold to about 15 Hounsfield units, negative predictive value of 96%. So the point is, if the lesion does not enhance, provided that you've done the study properly with the proper protocol, the negative predictive value, the probability that the lesion is benign, is very high, greater than 95%. Now, you can have false positive results. There are benign lesions like active or vascular granulomas that can enhance with contrast. You can have false negative results. If you have central necrosis and a malignancy, hopefully you'll recognize that this represents a necrotic area within a tumor. Also, low cardiac output might also impair enhancement. Nowadays, though, this is enhancement studies with CT are usually not done, as we usually use PET CT for further evaluation of lung nodules. And in a follow-up study done with multi-detector CT here, they were able to move up the cutoff value to 30 Hounsfield units. So in multi-detector CT, if you follow the protocol and the lesion enhances less than 30 Hounsfield units, the negative predictive value is quite high, on the order of 97%. Now, doubling time of pulmonary nodules, if you have sequential studies, can also be important in determining whether the nodule might be benign or malignant. Benign lesions usually have very short doubling times, less than 1 month, or very long doubling times, greater than 18 months. Inflammatory lesions can have very short doubling times of less than 1 month. You can have slow-growing nodules, benign nodules, like a hamartoma. That can be slow-growing. The malignancy that can be slow-growing is a bronchial carcinoid tumor, inflammatory pseudotumor, granuloma. These are other benign lesions that might be slow-growing. Fast-growing nodules with very short doubling times, usually these are inflammatory, like infection or infarction. The exceptions are neoplasms like lymphoma. Lymphoma can have very short doubling times, less than a month, or metastatic disease from germ cell tumors or sarcomas. These tumors also can have very short doubling times of less than 1 month. Now, if I show you 3 different types of nodules, this nodule is purely ground glass attenuation. This nodule is semi-solid, meaning that there is area of a small solid area within the nodule. The rest of it is ground glass, and this nodule is mostly purely solid. So which one of these would have the shortest doubling time, and which one of these would have the longest doubling time, if you had to guess? And the answer is that the solid nodule will have the shortest doubling time. So if these lesions are malignant, the solid nodule would be the most aggressive, and the purely ground glass attenuation nodule, again assuming it is malignant, would have the longest doubling time, and the semi-solid nodule with a mixture of solid and ground glass components would have a doubling time in between. So assuming again all 3 of these lesions are malignant, the lesion that starts out as purely ground glass nodule would have the longest doubling time, the semi-solid nodule about 15 months, and the solid nodule about 5 months. So this is why lesions that have ground glass in them, we usually follow those for a long period of time, for about 5 years before we can, and they should remain unchanged for 5 years before we can say that the lesion is benign and we're no longer concerned about malignancy. So here we have a PET scan on a patient who has a nodule, and notice that there is markedly increased activity there within the nodule. What could this be? Well, of course, we think about cancer in a case like this, but what can give you a false positive PET scan? Well, you can get a false positive PET scan from any inflammatory lesion. So especially granulomas from tuberculosis or atypical mycobacterial infections, those can give you false positive PET scans. On the other hand, here we have another nodule. This one has no activity. So again, this has a high probability of being a benign lesion. But are there lesions that can give you false negative PET scans? And here the answer is yes. A carcinoid tumor can give you a false negative PET scan, and bronchoalveolar carcinoma, which we'll also discuss in a few minutes, that can also give you a false negative PET scan. So PET is pretty good for evaluating solitary nodules, for determining whether they're benign or malignant, about 94% accuracy in diagnosing. Not reliable though for lesions less than 1 centimeter. So for very small nodules, PET is not reliable. We can have false negative results with carcinoid and adenocarcinomas, well differentiated adenocarcinomas, what used to be called bronchoalveolar carcinoma. Also, if the fasting blood sugar is greater than 150, remember sugar competes with the imaging agent here with the FDG. So that's why the sugar is checked before the PET scan is done to make sure the patient is not hyperglycemic. And also lesions that are small size, less than 10 millimeters, can also give you false negative PET scans. False positive PET scans you can get with any inflammatory lesion. So TB, sarcoid, rheumatoid nodules, any infection, any active inflammatory lesion can give you a false positive PET scan. So here we have a lesion, increased activity on PET scan. So our first thought here would be neoplasm. And one of the advantages of PET is we not only image the lesion in the lung, but we image the whole body. So this lesion here, markedly increased activity on PET. So that turns out to be malignant, but there's another lesion that also has increased activity in the lung, which is a metastatic focus. And then there is another metastatic focus here within the arm that also lights up. So with PET, we can not only evaluate the primary lesion there within the lung, but we can also attempt to stage the patient as we look for any abnormal activity elsewhere within the body. Now the indications for PET scans, so these are not hard and fast. Here I have some recommendations from the literature for when you might do PET scans. So if the patient refuses biopsy, or if a biopsy would be very difficult or poorly tolerated. If there are multiple lung nodules, then which nodule would you go after? Well, you can do a PET scan to determine if one nodule is more suspicious than another, or if you have a non-diagnostic needle biopsy. If the PET scan is negative, you can observe the patient. On the other hand, if the PET scan is positive, then you need to be more aggressive in those cases and probably should proceed to biopsy. So again, the workup for indeterminate pulmonary nodules, this is not written in stone. So if we have a new solitary pulmonary nodule, so if we have a prior study where there is no nodule, but a new nodule pops up, then we have to rule out cancer. So there you might think about doing surgery. If you have a solitary pulmonary nodule in an operable patient, you can do wedge resection. You have to be careful about your pretest probabilities of cancer. If we have a very low likelihood of cancer, then a negative PET scan has a 99% negative predictive value, and so you can observe the patient with serial CT scans. On the other hand, if you're dealing with a high-risk patient, then that increases the odds of getting false negative PET scans. So there, a negative PET scan only has an 86% negative predictive value. So PET scan, the results of the PET scan, often you have to interpret in line with your pretest estimate of malignancy within the patient. Again, in terms of workup for the solitary pulmonary nodule, this is not written in stone, and here's one algorithm from the literature for how we might work up a solitary pulmonary nodule. But again, this can vary between patients. Now there are some recommendations that we do have, so let's go through some of them. So if I tell you that this is an incidental 2 millimeter nodule in a trauma CT scan, what would you recommend for this patient? And so here what we would do is we would follow the Fleischner criteria for incidentally detected nodules, and in a low risk patient, if the nodule is less than 6 millimeters, usually no follow-up is required. If we have this 2 millimeter nodule in a patient with a history of hepatocellular carcinoma, what is the recommendation? Well, here the Fleischner criteria do not apply because the patient has a history of extrathoracic malignancy. So any nodule that shows up in a patient with a history of malignancy has to be followed very closely. And in this patient, the 3-month follow-up and the 6-month follow-up show that this nodule is enlarging. So this indeed was a metastatic lesion from their hepatocellular carcinoma. So a nodule like this that has some ground glass attenuation, a mixed attenuation nodule like this with a solid component in ground glass attenuation. These are cases where PET-CT can give you false negative results. You see in this case there was no activity there on the PET-CT scan. So these lesions that have ground glass attenuation, when they are malignant, are notorious for giving you false negative PET-CT results. So guidelines for management of incidentally detected nodules, these come to us from the Fleischner Society. So the criteria for using these, the patient should be greater than or equal to 35 years of age. And then for solid nodules, we would divide patients into low-risk groups and high-risk groups. And the idea here is to exclude nodules with a less than 1% risk of cancer from CT follow-up. If we have a non-solid or partially solid nodule that has ground glass attenuation, then this may require longer follow-up, up to 5 years, to exclude an indolent adenocarcinoma. The Fleischner Society guidelines do not apply if the patient is less than 35 years old, if the patient has a known primary cancer, if there's an immunocompromised patient with fever, if we're doing lung cancer screening, here we use Lung-RADS, if nodules are perifissural with typical morphology for intrapulmonary nodes. And also in the Fleischner Society guidelines and the newer guidelines, they tell us that if we have a young patient with a nodule of about 1 centimeter, we might consider a follow-up chest radiograph rather than CT for evaluating that nodule. So when we're dealing with solid nodules, again, these recommendations can get very complicated, but one thing to remember, what you want to remember, is the size threshold of 6 millimeters. If the nodule is less than 6 millimeters in a low-risk patient, then no follow-up is required as far as the Fleischner Society guidelines tell us. They do give us, as you read the guidelines here, they do give you lots of flexibility in terms of how you want to manage individual cases, but that number of 6 millimeters is important. Usually if the nodule is less than 6 millimeters, then the patient will not require a follow-up, especially if they are a low-risk patient. And then what we do for follow-up can depend on the size of the nodule. So if we have multiple solid nodules, here what we want to do is we want to pick the most suspicious nodule and then decide on your management based on what we think is the most suspicious nodule. So those guidelines here have also outlined for you. Now for subsolid nodules, for nodules that have ground glass attenuation, again, if the nodule is purely of ground glass attenuation, to note here for subsolid nodules, so here we do not divide into low risk and high risk groups. Here we treat smokers and non-smokers the same. So for solitary pure ground glass attenuation nodule, if the nodule is less than 6 millimeters, that does not require CT follow-up. So that might represent a focus of atypical adenomatous hyperplasia, and those usually remain stable over time. So if the nodule is greater than 6 millimeters, then we can do follow-up, and if there is ground glass associated with the nodule, we want to do the follow-up for 5 years because it can represent, can start out as adenocarcinoma in situ. So you want to follow the nodule for 5 years, and the nodule should remain unchanged before we can decide that the nodule is benign. If there's a solid component, a small solid component in the nodule, and the nodule is less than 6 millimeters in diameter, again, no follow-up is recommended. On the other hand, if the nodule is greater than or 6 millimeters with a solid component, greater than or equal to 6 millimeters with a solid component, then we have follow-up starting at 3 to 6 months. And again, we want to follow the nodule for 5 years before we decide that the nodule is benign, because these nodules might represent, if they are malignant, adenocarcinoma in situ or minimally invasive adenocarcinoma. And then if we have multiple subsolid nodules, they also give us recommendations for that. So here, if we have a pure ground glass attenuation nodule less than 6 millimeters, no follow-up is required, because at worst it is felt that this might represent atypical adenomatous hyperplasia, which is atypious proliferation of cells here, and this usually remains stable over time. This usually does not change. So if we have a pure ground glass attenuation nodule that's greater than 6 millimeters, then follow-up CT is first done at about 6 to 12 months, and then we will continue follow-up for up to 5 years. Some of these nodules can resolve on follow-up, and the differential diagnosis for these larger ground glass attenuation nodules include atypical adenomatous hyperplasia, adenocarcinoma in situ inflammatory lesions, or focal fibrosis. This particular example, this was a well-differentiated adenocarcinoma as a bronchoalveolar carcinoma. So another example here where we have a large ground glass attenuation nodule, and again this turned out to be bronchoalveolar carcinoma. So the point is that these nodules that are of ground glass attenuation require longer follow-up, up to 5 years, before we decide that these are benign lesions. If we have a ground glass attenuation nodule that develops a solid component, that should increase your suspicion for malignancy. So here you need to be more aggressive in terms of what we do about the nodule. Consider biopsy or resection. Now, another feature in a nodule that can increase your suspicion for malignancy are these bubbly lucencies. So if we see bubbly lucencies like this within a nodule, that also increases our suspicion for malignancy within a pulmonary nodule. And the Lung-RADS, that can bump up the Lung-RADS score to 4x. So for mixed attenuation nodules, if they have a solid component less than 6 millimeters, we want to do follow-up at 3 to 6 months, and then follow up to 5 years. And if it remains persistent or enlarges, then we want to consider biopsy. Here the differential diagnosis is adenocarcinoma, infection, or inflammatory lesions. Here we have a lesion where the solid component got larger 3 months later. So here you need a high suspicion for malignancy, and this was adenocarcinoma. So let's move on now to Lung-RADS. So according to Lung-RADS, what is the recommendation for a patient who receives a score of 3 on a screening low-dose chest CT screening exam? And so you can decide on what your answer might be. I'd give you a second for that. And the clue here is that the recommendations are the same as far as the score as what we would do in mammography. So for a score of 3, the recommendation is a follow-up low-dose CT in 6 months. So the scores here for a screening with Lung-RADS, these scores are determined by what we find on our imaging studies, and they also determine the management. So Lung-RADS is what we use for screening CT studies. These patients will usually receive these are smokers, patients with a history of smoking or current smokers, who will receive CT scans for screening at yearly intervals. So a score of a 1 or a 2, 1 meaning no nodules, 2 meaning nodules that are felt to be benign. So these patients, these are score of 1 or 2 is usually considered a negative study, so that does not affect the management, as the patient will return in 1 year for a follow-up low-dose screening chest CT. So a score of 3, the patient will get a low-dose CT in 6 months. And when we get to 4, now we are thinking more in terms of malignant lesions. So 4A, screening CT follow-up in 3 months, and 4B and 4X. Here we're thinking more and more malignancy as we progress to 4B and 4X. And then here we can be more aggressive. We might consider PET CT or tissue sampling in these cases, biopsy in these cases. Now, there's a new version of the Lung-RADS scoring system that was put out in 2019. So a few things to go over as far as the new version is concerned when we're reporting lung cancer screening studies using Lung-RADS. First of all, mean nodule diameter is measured to the 10th of a millimeter. So you would measure a nodule you'd measure the diameter of the nodule in the two largest projections, axial coronal or axial and sagittal. You would pick the two largest measurements, round those off to the tenth of a millimeter, add them up, and then round that off to the nearest tenth of a millimeter. So perifissural nodules, and we'll talk about those in a minute too, if those are less than 10 millimeters, they would receive a score of 2. A 30 millimeter nodule, that is ground glass attenuation, so this also receives a score of 2. So these patients then do not require any different management. They would receive a follow-up CT in 1 year. For the 4B category, a large nodule, so here a nodule that appears, a large nodule that appears on a follow-up study, the thinking is this might be an inflammatory lesion. So here they can do, or you might recommend a 1-month follow-up CT to see if this lesion gets smaller, if this is an inflammatory lesion. If it persists, then you do need to be more aggressive. Growth is defined as greater than 1.5 millimeter growth in terms of mean nodule diameter, or greater than 2 millimeter cube in terms of volume. So in the new scoring system, they've also added volume. You can report the size of the nodule either as the mean diameter of the nodule or as the total volume of the nodule in cubic millimeters. And then we've talked about the scores of 4A, 4B, and 4X. And what is different also about lung cancer screening compared to mammography is there may be other incidental findings that require follow-up, and that is what the S designation is for, potentially significant non-lung cancer findings. So if you happen to find a solid renal mass, and let's say there are no lung nodules, then the score for that patient would be 1S, meaning that there is a significant non-lung cancer finding that will require some type of follow-up or management. Now, suspicious features for lung in terms of these lung cancer screening studies: spiculation or unsharp margins, lobulation, any ground glass nodule that doubles in size in 1 year, enlarged nodes, bubbly lucencies, which we've talked about, retraction or displacement of fissures or pleural surfaces, high or inhomogeneous attenuation, and solid components, especially if they appear newly within ground glass attenuation nodules. So these are suspicious lesions. And then, as we've said, your score here also determines your management. So that is one of the advantages of using this type of Lung-RADS scoring system. So let's discuss this case. So here we have a nodule here on the current CT scan, and we notice that 2 years prior, this nodule was quite small. There it is there, right along the major fissure. So what do we think? Is this a malignancy or is this something else? Well, hopefully you also notice that this patient has some consolidation here in the left lower lobe. So this patient has a pneumonia, and this could represent here, it looks like an intrapulmonary lymph node, this benign appearing perifissural nodule, and these can enlarge, especially in inflammatory states like with pneumonia. So in a case like this, you would recommend a follow-up CT when the pneumonia has subsided to see if this nodule gets smaller or if it gets larger. If it gets larger, then you would be concerned about malignancy. But often these intrapulmonary lymph nodes that make up these perifissural nodules, often they may enlarge with inflammatory conditions, and then they may get smaller when the inflammatory condition, when the pneumonia subsides. So perifissural nodules are quite common. They're usually small, triangular, or oval in shape. Common to see them below the level of the carina, and they may increase or decrease in size. And they're almost never lung cancer. Here's the typical appearance, this kind of triangular lesion here. So that's a typical appearance for a perifissural nodule. Also, they're often located right where you have interlobular septae. So that's another typical feature of these perifissural nodules or intrapulmonary lymph nodes. So they're usually less than a centimeter, usually within 2 centimeters of pleural surface. They're common along interlobular septae, or especially common along near the minor fissure. They may be ovoid or triangular in shape. This one is triangular. These are ovoid, so it's common to see these ovoid appearing small nodules right along the major fissure, and usually these are not calcified. Another example, this one here is right along the minor fissure, which you can see on the sagittal reconstruction. Here's the minor fissure, here's the major fissure. So this represents a benign intrapulmonary lymph node, and you can appreciate the triangular shape better on the sagittal reconstruction. Here's a patient who has a calcified granuloma, and again, this triangular nodule here right along the minor fissure. Another example of an intrapulmonary lymph node giving us this perifissural nodule. Now, these types of very small nodules can be very easily missed as you're scrolling through axial CT scans here. So if you're looking for tiny nodules, if you're doing screening studies, what you might also do is look at these MIP reconstructions, maximum intensity projection reconstructions. So a 5 or 6 millimeter slab tissue here as reconstruction. As we go through it, the nodule can pop out because what happens here is you can see all the blood vessels connecting to each other, whereas that very small nodule that you can scroll right through on your regular images, on the MIP images, it tends to pop out here against the background of the blood vessels. So if you're looking for tiny nodules, these MIP reconstructions can be very useful. So here's a 5 millimeter perifissural nodule in a 54-year-old smoker. So there's the nodule there. What do you think we should do here? I'll give you a second to think about it. And it turns out that for this particular nodule, this is not our typical perifissural benign appearing nodule because there's a little bit of speculation and some distortion to the fissure. So because of that, you should recommend follow-up, either 3-month or 6 to 12-month follow-up for this particular lesion. So we can't assume that that lesion is benign, and you can see on the follow-up this lesion did get larger, so this was an adenocarcinoma. So perifissural lesions can be considered suspicious if there is speculation, if there is fissural transgression, if it crosses the fissure, if there is distortion of the fissure, and if it is a juxtafissural nodule not entirely associated with the fissure, as these drawings here show you some of these examples. So here you have a little bit of speculation. Here there's some retraction of the fissure, which you can see a little bit there, and also a little bit of speculation. Here it crosses the fissure, and here it's not completely against the fissure. So these then would be considered suspicious perifissural nodules. So these if these perifissural nodules have this type of morphology, we cannot assume that the lesion is benign, and the lesion will require follow-up. Okay, so here's our next example. We have a nodule here. 6 years later, it grows, and 12 years later, it grows. So this nodule has been there for 12 years. Well, what could this be? And here is the CT scan. You can see a little bit of calcification, but the other important feature here is this fatty attenuation within the nodule. So this is a hamartoma, and hamartomas can give you very slowly growing nodules, as in this particular example. And the fat within the lesion tells us that this is a hamartoma. So these make up about 5 to 8% of solitary nodules. They represent disorganized growth of normal tissue that may contain cartilage, fibrous tissue, and fat. So the cartilage can give us the amorphous calcification, the popcorn calcification, and of course if we see fat within the lesion, we can say it's a hamartoma on CT. So you can have this type of chondroid calcification or popcorn calcification within the nodule, and popcorn calcification, this type of calcification, can be seen in hamartomas. If we see it, it's very suggestive of a hamartoma, and hamartomas may grow slowly. They may also contain fat. So if we can see that there's fat within a nodule, we can say it's a hamartoma. A benign lesion does not require any further follow-up. Unfortunately, most hamartomas in clinical practice look like this: non-specific nodule on chest radiograph, non-specific nodule on CT. So this is why we include hamartoma in our differential of solitary pulmonary nodules. Now, what is Carney's triad? So this is a nice trivia question. So Carney's triad or syndrome, multiple pulmonary chondromas or hamartomas, gastric leiomyosarcoma or GIST tumors, functioning extraadrenal paragangliomas. That is the triad, and it's very rare, usually found in females less than 35. So here's the GIST tumor here, and this patient has multiple hamartomas there within the lungs. Now, here's another example of a nodule. What do we think of this nodule? I'll give you a few seconds to look at that and tell me what you think. Few things to notice. It is lobulated. It's at the lung base. Notice also we have these blood vessels heading towards the nodule. So here you should think of pulmonary arteriovenous malformation, which is confirmed on the angiogram. Here is the feeding artery, enhancing nodule, and there is the draining vein. So these pulmonary AVMs represent abnormal communication between the artery and the vein. So here's the artery draining vein. So they can be simple or complex. Simple if there's a single feeding vessel, complex if there's greater than one feeding vessel. These can be multiple, especially if the patient has Rondeau-Osler-Weber disease or hereditary hemorrhagic telangiectasia. That is autosomal dominant. So if you find one, it's very important to look for others. And these can be quite small, so you have to look very carefully for multiple pulmonary AVMs if you find one pulmonary AVM. So symptoms: shortness of breath, cyanosis, hemoptysis, orthodeoxia, meaning hypoxia in the upright position, and brain abscesses. These are all due to right to left shunting through the pulmonary AVM. That right to left shunting also bypasses the filtering mechanism of the pulmonary capillaries, so bacteria in the pulmonary venous circulation can get to the systemic circulation, hence patients can develop brain abscesses. So these may be lobular on chest radiograph, often found at, closer to the bases of the lungs in the periphery. On chest radiograph, look for a feeding artery, draining vein. That can be a radiographic finding of a pulmonary AVM. On CT, they're quite characteristic. They can have the serpentine vessels, feeding artery and vein. They are markedly enhancing here when you give contrast, and usually a pretty easy diagnosis on CT. They can be multiple, so if you find one, you look for very carefully for others, and especially with hereditary hemorrhagic telangiectasia, they can be multiple and they can be small, so you should look carefully for others. Usually asymptomatic AVMs are treated if the feeding vessel greater than or equal to 3 millimeters, and they can be treated with embolization, as in this example here. So that is the criteria: feeding vessel greater than or equal to 3 millimeters for treatment of an asymptomatic pulmonary AVM. One other lesion to discuss: inflammatory pseudotumor, plasma cell other terms for this: plasma cell granuloma, mast cell granuloma, or histiocytoma. So it's some reactive granulomatous inflammation, and really we're not sure what the inciting agent was for the granulomatous reaction or the organizing pneumonia. So this has a non-specific radiographic appearance as a solitary nodule, might have calcification, and I mention this because sometimes you might come across this and the patient goes to biopsy and the biopsy results come back as inflammatory pseudotumor. As in this case, you can see a little bit of ground glass attenuation associated with the nodule, but the result of the biopsy was inflammatory pseudotumor. So we'll finish with this. So I'll show you some examples of multiple nodules. You tell me what are each of these nodules. So we'll start with this case here. Hope you notice the lobulated appearance. It looks like there are vessels going towards a lesion. So here we're going to think of pulmonary AVM. This lesion here, it looks like there's low attenuation here. That is the same attenuation as fat. So here we would think of a hamartoma. Here's a lesion that might have popcorn calcification. So again, you might think hamartoma. And this I did not discuss today. But notice that we have vessels that are swirling in towards the lesion. There's a comet tail sign, and it's based right along the pleural surface. So this is a small focus of rounded atelectasis. Okay, so that concludes our lecture on solitary pulmonary nodules, and I thank you for your attention.